everybody. Welcome, Dr. Andreas Kremer. It's lovely to see you. You're dialing in from where, Switzerland?
Yes.
Well, you're most welcome to rainy Scotland, rainy Britain. Right, we'll crack on, everybody. We've got a good few questions, Andreas. We're short on time, but he's gone. We're short on time, but we'll get through them as quickly as we can. Okay, are you all right with that?
I'm all right with that. I
brilliant.
took now
And
out
as
this
always,
artificial background, so that's the real background, and I hope maybe that this works then much better. At least from my side, it's more fluent.
It looks
Yeah,
very
my sincere apologies for the technical issues today. It's not about the weather. The weather is as bad in Switzerland as it is in the north of England.
So as usual, everybody, we can't do singular diagnosis or comment on somebody's particular own PBC because that would be against the rules for us looking after you, and we can't ask Dr. Kremer to make comments when he doesn't have the full picture, but we'll do our best to get through as general as possible. So first question up, Andreas. I was commenting before you came in, what a lovely name Andreas is. It's lovely. Right, I have PBC and normal liver function. Would I be able to take creatine? And I don't know what creatine is.
Yeah, that's a good question. I mean, creatine is in these days very popular, in particular for those people who want to have more strength for exercising, because the energy unit in our muscle is creatine phosphate. And if you take creatine, you enrich your body for the proper molecule, which is then gets a phosphate added. And out of that, the muscle can make ATP. That is the energy our body deals with. And this is a rapid process. So all the, let's say, the bodybuilders eat a lot of creatine to have just a little bit more energy supporters in their muscle system. And I think there is no risk at all to take creatine. I don't foresee any problem with the liver because it's a very small molecule. It's not metabolized by the liver whatsoever. And in particular, if the liver function is good, that's not an issue. The only problem is that if you are the next time at your gastroenterologist, hepatologist, GP, and she or he draws blood, then the retention parameters, so the kidney parameters, will be false high, because we tend to measure kidney function indirectly by the final product of creatine, which is creatinine. That is then this molecule which is broken up and secreted by the kidney. Now, if you artificially take a lot of creatine, then this kidney parameter goes up while your kidney function is still very normal. And this has to be kept in mind. So you should tell that your that she or he knows, oh, the kidney function has not now deteriorated since last time you only have started taking creatine. I think this is important because we see that once in a while also with very young and people go to the fitness and then you think, why is the kidney function now wrong? And the kidney function is wonderful. There is another parameter to then correct for that. That is the cystatin C. That is independent of muscle function, amount of muscles, but that is not the regular way how kidney function is determined. So this is the only issue I want to give with that. But otherwise,
how is creatine taken? Is it a supplement? Is it?
Yes, it's a supplement. You can buy it. I think these days in a lot of stores via the internet. It's not a problem. I think you can take it, and maybe also for those who may have some kind of fatigue, this may help a little bit to have a little bit more energy in your muscles, to be able to train a little bit more, and that could be a positive thing.
Which builds into the feeling of well-being. And of course, you're buying into more energy. The more you do, the more you're able to, back to the movement is medicine that we all. Okay, right. Now here's a belter for you. Is it safe to take weight loss injections? Now, there's another question. Is there a preference? We can't really comment, I wouldn't have thought, on the preference. Maybe you can, but is it safe? because the whole world seems to be on weight loss injections at the moment.
Yeah. It's super popular, and I mean, a Danish company, was richer than the social inland product results of the whole country. So yes, this is super popular. I personally think if you want to lose weight, you shouldn't do that on your own. You should always take, endocrinologist or, gastroenterologist, internal physician along, to explain a little bit. It's not a no-brainer, to make that clear. I think it can result in a significant weight loss, and we have seen a lot of studies. There are a lot of products, and I think, let's say roughly between 8 to 25% weight loss is possible, at least in clinical studies, which can be of help also for the liver, because we know if additionally to PBC, we have a fatty liver disease, or now called steatotic liver disease, that can harm the liver twice, or is then, maybe an additional risk factor for, that the liver disease worsens throughout the years. And in that case, I think weight reduction can be one solution. But still, I'm personally always a person, I try to change the way how we eat. And we are what we eat, and we should rather think, can we at first sight change a little bit our eating behavior? Think more about eating interval fasting, 16 hours during daytime. You shouldn't eat something maybe only 6 to 8 hours. And that helps a lot, because we move our, anabolic situation. We continuously eat. Everywhere you are, there's a bakery, some store, always something to eat. That was not there 1,000 years ago or 10,000 years ago. We went to the forest, we saw some leaves, and we were lucky if we caught a rabbit. And that was the situation. And this is something we should reflect. Previously, thousands of years ago, there were long times where we never had anything to eat. And that's why our liver was trained to store. And the more our liver could store lipids, store fat, then we survived. And, now that there's food all the time, this is not ideal. And our liver starts to build too much fat in our liver. And that is not good on the long term. So ideally, we try to change a little bit the way how we eat, how we live, in the sense that we have catabolic phases where we don't eat anything. What is allowed is water, unsweetened tea, and unsweetened coffee. That is good for the liver, and that you can drink even several times a day. But really, a fasted state is important. Now, if that doesn't work for whatever reasons, and you tried a lot of things and you still want to lose weight, then I would agree that these GLP analogs, GLP-1 analogs, or glucagon dual agonists, or there are even triple agonists in development, they really work, and this can be done. One word of caution here are for all people who live with liver cirrhosis, because once we have reached the stage of liver cirrhosis, these drugs tend not only to reduce our fat amount, they also result in a reduction potentially of muscle tissue. And classically, when we have the end stage liver disease, the stage where liver cirrhosis develops, we lose more muscle mass. And this is something actually we want to avoid. And in such a situation, we are very cautious. This needs a very close monitoring, that needs a lot of education. So everything before cirrhosis, I think, is fairly safe. But from that point, you have to be cautious.
It's a good point you make about the food and the way we eat. And I think whatever happens in the States happens to us 5 years later. But my generation, we were post-war. And my mother remembers the rationing, and we were brought up in 3 meals a day. There was no such thing as a snack. And we didn't have all these outlets, as you say, bakeries, burger stores, and everything else. The whole way we eat has changed. Yeah. But I still stick to my 3 meals a day. I can't snack. It's just not in my DNA. It's not that we have brought up.
Yeah.
But do think about
I fully
that.
agree. Yeah,
I would say to people as well, for any of you who've got a snack cupboard, I would ask you the same question as I have to my 2 sons. Why? Why do you have a snack cupboard? Have a piece of fruit. Let
Right.
the biscuits and cakes, throw them out.
Yeah. And I think it's very important to reflect a little bit that I always say eating once in a while fruits is good, but don't drink it because it's too much,
Yeah,
in
sugar.
particular fructose. Also,
Yeah,
smoothies is not good for the
yeah,
liver.
yeah.
And in particular, everything which is long lasting, everything which
Yeah.
is packed, which you can eat in 6 months,
Mm,
that contains a lot of, this hyper raffinated or hyper processed food,
yeah,
as it is properly called.
yeah.
There's a lot of sugar added. And so in that regard, I think we should always think the healthy food contains a lot of fibers, so uh,
Mm.
vegetables and fruits as a food.
Homemade soups,
Yeah,
I
yeah,
think, are the
that,
best
that,
thing.
yeah, but it
Because
takes time. That's a lot of effort, Colette. And many people think, oh, it's much easier to take something along. And I agree on that. It's a little bit, but it needs a
if you
balance,
make a big pot of soup,
Yeah,
as I do, and I maybe section it up and freeze it,
yeah,
so you've got plenty there. My sons come into the house and they go straight to the freezer looking for my soup. You know,
yeah. That's good. That's
so
good.
I'm a big soup fan. I'm a big soup, but yeah, good points made. Which takes us on to the next question, really. So why do I feel so tired with PBC, and what would help? So I think we're going to split this up a bit, and I'll tell you what would help, and it's been proven beyond any doubt. Movement is medicine, and no matter how tired you feel, and by goodness, we really do feel tired, and it's not just a sleepy tired, lethargy, heaviness. There's an awful lot of words to describe how we feel. But trust me when I say to you, get your coat on and go out and have a walk around the block. Go and do something physical. Don't give into it. Don't lie down. Just do something, even a small amount, a few things in a day, but you will buy into more energy. It's been proved. Newcastle University did a huge study on it. And I know it's really tempting just to sit down and flick on the telly. By all means do, after you've had 15, 20 minutes out for a wee walk. What would you say to that, Andreas?
I couldn't say it better. I mean, I think it's important for our listeners to understand that tiredness does not mean tiredness. It can mean very different things to different people.
Yeah.
And I think I always tell my patients in my outpatient clinic that I think there are in particular two major parts. The one part is the peripheral fatigue tiredness, where you have a muscular exhaustion much quicker than maybe somebody else. And Professor Dave Jones has also, analyzed that and put that on a passive physiological understanding. The muscle becomes quicker, exhausted, and more lactate is produced, not adequately restored. And this is something I would fully agree that has a strong benefit on regular movement, mobilization. And it's for me the same. If I had to have night shifts and I have to sit in front of the computer and have to think mentally, that doesn't work. But if I walk around, then my fitness is much better. And this also holds true for this peripheral part. Now, the central part is a little bit different, where patients or people may say this is more brain fog, I cannot concentrate anymore. So in the morning it may still be good, but then afternoon it's impossible to do these mental relevant aspects. And there's a significant overlap there. You cannot separate it totally, but these are different things. Also there, I think, movement helps a lot, whatever you like, actually, whether you like to walk outside or to run up a couple of stairs and or go swimming or whatever. That doesn't matter, actually. It's more the movement. I would fully agree that this is of help. To be honest, I think the most important part is empathy, that this symptom burden is part of the disease called primary biliary cholangitis. And we just have to accept it a little bit. The problem is that we have not properly understood which receptor, which molecule is driving that. So if we we could say, okay, we develop a drug specifically for this receptor and then it's solved. But it's more complex like this. There are currently drugs in development where the future may tell us whether we have a dedicated way to improve that, but to some extent, we are a little bit in a situation, in contrast to itching, where we have dedicated drugs that really work on a placebo-controlled basis, that for fatigue, for exhaustion, for tiredness, this is much less the case. And so it's a little bit of trying to exclude other things. We have to keep in mind that the thyroid function is important. Hypothyroidism is also an autoimmune-driven disease in some patients that can be easily corrected with a pill, the thyroid hormones, if that is present. So we should always look for, is there any other reason we can treat? So treat the treatable. Professor Jones always says, ameliorate the ameliorable. So optimize everything. Also sleep hygiene is very important. I tell to my patients, you have to really try. If you go to bed, if you sleep, then try this is really sleeping and not reading, watching television, doing other things on the iPhone or whatever that keeps you rather awake and your brain has difficulties to fall asleep. There are many things, and this takes a physician with experience to negotiate and try to figure out an optimal way of improving that.
Yeah, and also this. Because if you're dehydrated, you won't necessarily know, you won't necessarily feel thirsty, but my goodness, you'll feel drained. And it's happened to me now and again if I've had long drives and I've run out of water. But that holds a pint, and that's old money. We don't do litres in my house. And I have maybe 6 or 7 of those in a day and an evening.
Yeah, very good point.
Yeah, it's good. So, on the subject of drinking, are you able to drink alcohol with PBC? Now, I have heard an awful lot of things over the years. And I remember one doctor in Sheffield many years ago saying, no. Another doctor said, yes. The thing in Britain seems to be, in the UK, seems to be within the normal limits unless you're told otherwise. But I'd like to hear your take on it, if I may, Andreas.
Yeah. I mean, we have had this year the EASL conference, the International Liver Congress, and there the new approach was to say zero alcohol is the best. And to be honest, I'm not a fan to prohibit everything. That's not realistic, to be honest.
Yeah.
So I personally tend to tell my patients with PBC that you have already a liver disease, and any additional potential toxic substance may harm the liver more than in a healthy liver.
Mhm.
That does not mean that you're not allowed to eat a piece of chocolate or a cake, which is also not the best thing for your liver if you take too much of that. And the same holds true for a glass of wine, a pint of beer, or whatever you once in a while like to drink. And I think it very much depends on the stage of disease. So when I say zero alcohol, I tell this to my patients who are cirrhotic. Then I really say, okay, we are in a stage of disease where every potential additional factor is really maybe too much and may rather, accelerate, a deterioration of liver function, resulting in decompensation and complications. As most of our PBC listeners have not a cirrhosis, luckily, this is not the case. And then I say, once in a while, a glass of wine, champagne, or beer, that is not a problem. But we have social events, we have a social culture, and I would not disagree. I'm not a 0.0 person in such a situation. And on the other hand, I would also say that 2 glasses of wine per day are certainly too much for a PBC liver. I wouldn't recommend that. So it's the amount makes the toxic aspect of it, but that holds true for a whole chocolate every day. That's also not good for the liver, and we have to keep that a little bit. We have to balance that a little bit, and this is my personal recommendation.
Okay. That actually sounds a very good idea. Although I must say, at my first husband's funeral, it was a very large funeral. He died many years ago. My hepatologist came along. I said to him, "Please, may I have a brandy?" And he said, "I'll get you one."
That's good.
So, as you say, in
Yeah.
exceptional circumstances.
Yeah.
Okay, so I'm feeling a bit sorry for this person here. I have PBC and AIH, and I'm struggling to sleep as a result of steroids. That is awful. I've read that magnesium supplements can help with sleep, but not sure if my condition will allow me to take them. So it's awful not being able to sleep. It really is, particularly on steroids. So what do you think of magnesium?
Yeah, to be honest, I don't know whether magnesium helps sleeping. If you take too
Yeah,
much magnesium, you get diarrhea.
yeah,
So I don't think that this may be the best alternative approach. To be
yeah,
honest, I mean, the first thing is I always, question a little bit this variant syndromes as they are called. So previously they were entitled overlap syndrome. So PBC overlaps with autoimmune hepatitis, two more or less independent immune mediated liver diseases. It's rare. It's rare in a rare liver disease. So that is, making it even more rare. And I always, doubt a little bit the diagnosis. There are indeed real overlaps or variant syndromes. I agree on that, but I always, I'm a little bit cautious. So when you have that and then you should normally have significantly elevated transaminases. So this is ALT, AST, so the transaminases, or GPT, GOT abbreviated on your lab results paper. Whereas PBC classically has low transaminases or only mildly elevated transaminases, and more the cholestasis parameters, gamma GT, alkaline phosphatase, maybe even bilirubin may be increased. Now, if transaminase is really up and you take steroids, as a result that we believe this is a variant syndrome, the transaminases should come down significantly in a relatively short time. And normally we give steroids in such situations, we taper that relatively quick. Every week we go down with the dose. And we know that steroids, if you take a lot of them, they make you nervous. They make you feel like you feel like overloaded. Your battery is overloaded, and you cannot sleep, and you're nervous, and so on. That is a classical adverse event of steroid treatment, but that totally disappears again once you have tapered the dose. And normally we talk about a very few weeks of a relevant dose, and then you come down relatively quick to 15, 10, 7.5 milligram, and then this should be totally gone normally.
So we suggest perhaps that this person go back to their doctor and ask, are these steroids going to be reduced?
Yeah, I mean,
and tell the doctor that you're
yeah,
not sleeping.
yeah. Tell the doctor this is a problem for me. They are, classically, we don't want to have. If there is an autoimmune hepatitis component, we don't want to have steroids on the long run. This is only a temporary treatment, and normally we taper that on a weekly basis. This is my recommendation. And then all these adverse events are gone. And normally you should then add, if we see a treatment response, if that works, we would believe it, and then we will switch to non-steroidal immunosuppressive drugs such as azathioprine,
That's what I was thinking, azathioprine, yeah.
MMF, mofetyl mycophenolate, or others.
Yeah.
And if, on the other hand, you could also argue, if we want to use steroids for whatever reason, and you have too many adverse events, and then there is one steroid, which is called budesonide, which has less systemic effects that could also in individual cases be an alternative. So they are alternative drugs, and ideally the way is to get rid of the steroids then maybe in a more rapid approach than initially, which was planned. That would be a little bit my recommendation. And keep in mind, if you take steroids, protect a little bit your stomach, take a proton pump inhibitor for the time you have higher doses. Look for the bones, check your bone density if you take steroids on the longer run, so a densitometry, and take vitamin D, because vitamin D is important not only for your immune system but also for the bones, and steroids rather demineralize your bones. So that is something, in general, I recommend to take every PBC person vitamin D, because the liver produces this form of vitamin D, and the sick liver produces a little bit less, and there's a good reason to supplement that.
Yeah, that's an excellent idea. Okay, there's a question here. It's a local question. How do I find a nurse lead clinic? I live in Dorset. I don't know where nurse lead clinics are. I think you should go to your GP and ask, or perhaps look online. If not, give us a ring at the office and let's see what we can find out for you. Okay. So there's a big confusion here. The question is there information on systemic system sclerosis or scleroderma and PBC? I've read this is called Raynaud's syndrome, and wonder if this is the case. I'm diagnosed with both. They're actually two different things. Raynaud's and scleroderma are very different things. And before Andreas replies to that, I would say to you to go onto our YouTube, because we have PBC and everything else, because people with PBC, which is an autoimmune condition, we quite often get another one. I've got Sjogren's syndrome, we see a lot of thyroid disease, etc. So go and look at YouTube and see what you can find. There'll be something there. If you can't, give us a ring and we'll find it for you, or if we haven't done it, we'll do it. So, but they are two separate things, Raynaud's and scleroderma. Andreas?
Yeah, excellent. I mean, I think it's wonderful that you say it. It's, PBC Foundation is an excellent opportunity to get in contact also with individual talks and further information into that. Yeah. And I couldn't describe it better. So we talk about two different immune-mediated diseases, as we can have Hashimoto thyroiditis, also more commonly in PBC. And so this is often, a classical, limited cutaneous form where you find certain antibodies, the so-called anti-centromere antibodies in the bloodstream, such as the anti-mitochondrial antibodies are for PBC. The anti-centromere antibodies are seen in systemic sclerosis. And both are, one autoimmune disease is more commonly associated with another autoimmune disease. This can be autoimmune hepatitis or that. It's called as a complex Raynaud's syndrome when it's together, as it was first described by Professor Reynolds, I think in the 70s. And indeed, this is something which needs individual treatment. It's independent. You treat PBC, you treat systemic sclerosis. These are independent approaches. You follow them differently. Systemic sclerosis, and you need ideally a rheumatologist who takes you along, who follows you. That would be my recommendation.
It's also, I think, Andreas, it's also fair to say as well, I mean, I'm one of 7 children and I'm the only one that's got PBC. So it's only nice people get PBC. You understand this. This is a medical fact. Now, yes. What's interesting, my Irish side of the family, there's celiac disease, there's scleroderma, there's diabetes. It's not uncommon to have other autoimmune thyroid disease. I think 3 of my sisters got thyroid disease. So it's not uncommon. You see this in families, but as I say, the very nice ones get the PBC. So now I'm going to go with a quick question. Because we mentioned about autoimmune conditions and PBC, somebody has said, could PBC have been triggered by COVID? Absolutely.
No, I mean, that is certainly not the case. And also about all, whether vaccinations then could trigger some things, that there is no evidence for that. And you have to believe me, I mean, billions of people were vaccinated. Yeah. And, that was certainly not the case. If anything was the case, then the diagnosis of PBC was in this period made a year later, because you didn't get an appointment at your GP or gastroenterologist. So there is no link to that. And the link we have so far with infections, Andrew Mason has shown that in certain preclinical models, if you infect those models with a certain virus, then you could see, antimitochondrial antibody formation and some kind of very early alterations in the liver. We have seen that certain bacteria have similar structures that can also result in, an immune phenomenon that causes antimitoral antibody formation, that illustrates a little bit that certain infections may trigger our immune system to then falsely recognize our small biliary epithelial cells in the liver as foreign, and then suddenly they think they have to attack it. What is exactly the mechanism behind it is unclear. We call it molecular mimicry, where a certain bacterial structure is similar to a structure in our human body. And then, by defending against this bacteria, we develop immune cells that then falsely attack other cells. And so rather, vaccination protects us maybe from signs of autoimmune phenomena, but COVID as a virus, so the SARS-CoV-2 virus, that certainly has not made PBCs not associated. We haven't seen any increase in PBC new diagnosis since the pandemic.
It's interesting what you say. So the foundation I started, it'll be 30 years next year, we're going to be celebrating, okay? So perhaps maybe in the first 10 years during that time, I'm sure you know Professor James Newberger.
Yes.
So James and I have worked together over the years, and he was the head of our medical advisory. And there was a time many years ago that, and he still feels that there's something in it, that there was some kind of retrovirus that was entered the body and long since gone and triggered various mechanisms. Now, as you know, I'm an accountant and not a doctor, but what he was saying is really sort of what you're alluding to in terms of possibilities as well. Is that reasonable to say that?
Yes.
Yeah. Interesting, weren't we?
Yep.
That's PBC
Absolutely.
people.
Absolutely.
Okay, so somebody has been diagnosed with PBC and they've been put straight on to URSO, although the blood tests are normal, and they still haven't had their FibroScan or seen the consultant, because in this country it takes a wee bit longer, Andreas. And the question is, have they been put on URSO too early, prematurely, before having the FibroScan, etc., and having normal bloods?
I mean, if a patient has normal blood values and classically then auto antibodies such as the antimitochondrial antibodies or AMA M2 or maybe PBC specific anti-nuclear antibodies, they're also called SP100 or GP210, may be present. But in such a situation, I tend to say this is not yet PBC, this is AMA positivity, for example, or GP210 positivity with normal lab values. And if there are no symptoms, if there is no fatigue, no itching, I tend to only follow up these patients. Of course, they get a sonography and we do elastography, but once the alkaline phosphatase, the gamma GT, the bilirubin, everything is normal. There is, if not a biopsy has been taken of the liver, illustrating us that there is anything ongoing, but otherwise I wouldn't say this is yet PBC. This is a, let's say, immunological situation where potentially PBC may occur at some stage in the future. Now, the question is, of course, how often does this occur? This is very difficult to say because there are different cohorts who have been followed up, and depending a little bit on the cohort, that ranged, let's say, roughly between 5 to 50% the next 10 years. Now, if you're lucky, you belong to the 5% cohort, and then 95 out of 100 didn't develop PBC. If you were in the 50% cohort, I don't know why, then this was more common. But for me, in such a situation, I tend to say, look, there are autoantibodies which may reflect some immune process ongoing in your body, but that doesn't mean you need a therapy, because how do you follow also therapy is a little bit, if something is normal, we cannot make it more normal. That's already the best thing we can approach.
It's interesting, Andreas, because this person said that their hepatologist put them on URSO. Now, a GP can't prescribe it without the authority of the hepatologist. And the fact that this person is seeing hepatologist not a gastroenterologist who sometimes doesn't know as much as a hepatologist, or just a general physician. I'm of a feeling that there's maybe a bit more to this story than what we've been asked. I find it interesting that the hepatologist has gone ahead with this. But you know, I would say to this person, why not ask? You know, drop your hepatologist an email.
And
say that you've read various things. That's reasonable to do,
absolutely.
Andreas?
Yeah, absolutely. I would always say, look, I have read this, and what do you think? Is it really PBC already, or is it only the proof of autoantibodies? And only the proof of autoantibodies is not necessarily, reflecting the full disease. I mean, you don't make anything wrong with her. So to be honest, it doesn't harm your body, because we all have it already in our body. I also have urso in my body in a small amount, and we just enrich a little bit a bile acid which is less toxic. So this doesn't harm us. But on the other hand, you shouldn't need something which is not needed to take. And so in that regard, I would also just discuss that a little bit. And maybe there has been older values or other reasons to say
something else in the picture. No, I think that's great.
Symptom burden could be something, for example.
Indeed. So we're almost there, Andreas. We're doing jolly well. Which liver function blood tests are carried out for checkups are important? Well, we know we'll always look at the bilirubin. They'll look at the alkaline phosphatase, which is absolutely vital. And of course, most doctors look at the gamma GT or the GGT as well. But they tend to do just the whole lot, don't they, Andreas?
Yeah, absolutely. I mean, Collette, and you mentioned that we have so-called surrogate markers. Surrogate markers reflect a little bit the way that they are relevant for the prognosis. And alkaline phosphatase is the best one. So the lower alkaline phosphatase goes under treatment, the better that is for your prognosis. For the bilirubin, we always want to have it normal. For alkaline phosphatase, we may not always be reaching that aim, despite the fact of novel drug developments. But we have several opportunities. And so in that regard, I think we are very happy in the current situation for PBC, or people living with PBC, because we have different treatment options to optimize the treatment regimen. Now, what is the best follow-up parameter? To be honest, we have a little standard for certain diseases which we followed up always. And for us, we would always do in certain intervals, depending a little bit on the disease stage, the transaminases, the cholestasis parameters, so ALT, AST, alkaline phosphatase, gamma GT, and bilirubin. That would be our classical pattern. We don't need IgM for follow-up. It doesn't make any sense to follow up on autoantibodies. Once you have measured them, you don't have to measure them any second time. There is no point of doing that. We look for kidney function. Always look once a year for the thyroid function. We look for the blood count. We look a little bit for the coagulation system. Once in a while, we also determine albumin. That's a little bit depending on the disease stage. But the classical 5 liver tests, including INR as a function test, as a synthesis test, that should be included regularly. And once a year, I always say thyroid stimulating hormone as a thyroid function, because hypothyroidism is so common in people living with PBC. So that is recommended. Once a year, elastography is a non-invasive test to look for liver stiffness. And that is a little bit how we would follow up our patients. Vitamin D is something I tend to determine once in a while.
Okay, so we've got a question. It's come through the electronics on my phone, and it's here. So on the lowest dose of virtue for your weight, and you've not fully returned to normal ALP GGT, does it make sense to increase it? So just hang fire for a second, because I'm going to show you. This is the chart. Have you seen these before, Andreas? This is a magic tool by the PBC Foundation, and it's how to calculate what dose you should be on. It's an imperial for old people like me, and it's also in metric. So if you do not have this, then get one from the foundation, and we have it online. So whatever your weight is, how much urso you take, and you stick to it. However, do check your weight because sometimes people can gain a wee bit taking our so sometimes in a bit. So that is how I would respond to that. And Andreas, so what are your thoughts? Does it make sense to increase it if the LP is not dropped as much as they would like?
I think I fully agree that the dose should be closely monitored, and we roughly say 13 to 15 milligram per kilogram body weight is roughly an ideal dose. So if your alkaline phosphatase is still elevated and you take, let's say, 750 milligram and your body weight is 75 kilogram or 80 kilogram, then of course you should increase the dose up to 15 milligram per kilogram body weight. But I wouldn't, if you take already 1,000 milligram, I wouldn't go to 1,500 milligrams to titrate that up to 20 milligram. That doesn't make sense. There is no data supporting that. You may even be able to overload the system. It's bile salts, they have to be secreted, that there is a machinery. So if you overload the system, that is not meaning that you do something better. So in that regard, check the dose, check your body weight. Keep in mind roughly 15 milligram per every kilogram body weight. That is approximately the dose we should use. If that is not achieved, titrate the dose up if possible, if tolerated. There are also sometimes patients who say, I have a little bit of GI problems or too much is not tolerated. This can be the case. If it's not well tolerated already at low doses, change the supplier. I would recommend that maybe some additional substances. Lactose can be a problem, can cause diarrhea as well. That is our recommendation. Many companies produce ursodeoxycholic acid, and but don't exaggerate with the dose.
Yeah. Okay, we're coming to our last question actually, and I don't know what's happening over in Switzerland, but in the UK, rifampicin is becoming difficult to obtain, and although it's an antibiotic, it was given really for tuberculosis in the old days. Well, it still is. It has been very, very helpful to the itch in a large number of people.
Yes.
So other medicines are available, but to start at the first line, most people probably have started off, what do they call it, Questran, and it's the powders in the water or the juice. It's like gloop, and you're expected to drink it. And I would say, and it's not on the packet. I remember contacting the company saying, you should have on the packet the instructions before and after breakfast in the morning. And they said, no, it's not given for the itch. Well, we know it is. But there is those kinds of things. But there are a number of treatments, aren't there now, Andreas, for the itch?
Yeah, I fully agree. I think, the anion exchange resins, we tried in our patients suffering from itch for insurance reasons mostly, and in most cases, this the palatable taste, you have said that it's really horrible. And I always tend to tell my fellows, you're only allowed to prescribe Quantalan or cholestyramine if you have once taken a bag before your breakfast and after breakfast and then go to work. And then you may reflect that from a different point of view. Now, as it doesn't work in most cases, we don't tend to prescribe it longer than 2 weeks because there is no point in my perspective. And then, we know that rifampicin works very well. We have not a supply problem, to be honest, so far. Luckily, you need much lower doses than the antibiotic dosages to treat, for example, mycobacterium infections. But there are also fibrates off-label available that can help for itching. There are novel PPARs available. They have had quite promising data on itching, and I personally think that this PPAR agonism, so this is a transcription factor, these also the novel drugs bind to more further developed than the old fibrates, that attenuates itching. We also have some kind of ideas about the mode of action. And then we have rather had obeticholic acid and FXR driven pathway that rather worsens itching. That is a little bit, a contrary, despite that both drugs improve our liver tests. And in that regard, I think it's quite exciting. So I think in particular, seladelpa has nicely shown that, but also elafibranor had some potential antipruritic effects. Fibrates, bezafibrate works much better than fenofibrate in my perspective. So that can be tried next to rifampicin. There are other drugs which are then third, fourth, fifth line usage. I think, the PBC Foundation also something where it can give help, also on non-drug treatments. You can do a lot of things around it. I think we can make a whole hour discussion on how to, deal with a significant itch in PBC. But if you have problems falling asleep, you wake asleep, then latest, I personally always think this is the time point when you need a drug treatment, when you need improvement. There are currently clinical trials ongoing with novel mode of action, which are quite intriguing. They work as well. So discuss this with your treating hepatologist, gastroenterologist. They know about these novel drug developments, maybe about ongoing trials where you can be, finding help and support, and look for experts in the field who are willing to support you more if you don't get that with your GP or other internal physician who may not have the experience with such a symptom burden.
Yeah, it's a good point. I'm sorry to do this too. Have you got time to go back to one question?
Yeah, very briefly.
Yeah, very briefly, I do humbly apologise to Siobhan. I appreciate we've run out of time. Thanks for the session. I wanted to note my question was not about Raynaud's, but about Reynolds. Reynolds, which I have read is a combination of PBC and systemic sclerosis. And I wanted to know if this is true.
Yes, this is true. It was described by Professor Raynaud. It has nothing to do with Raynaud, with the the vascular problem in the periphery. That was first described by a physician, and this is PBC and systemic sclerosis. But this is purely a name; it doesn't tell anything more. It was first described, but it's independent diseases. It's not a it has nothing to do. It's independent passive mechanisms, and it was just described at this stage when he didn't have autoantibodies to prove that, at that stage.
Okay, that's great. I do humbly apologise. Well, Andreas, that's fantastic. You've answered a lot of questions very thoroughly.